Hello and welcome to this critical care teaching video on the management of asthma. We're going to take a look at the background to asthma within critical care and why it is so very important. We'll have a look at difficult asthma and when you should be expected to be called about these patients. We'll also touch on what you should expect to have been done before you get there, and then we'll have a look at some of the difficulties we have within intensive care and some of the treatments that we can provide in intensive care that cannot be provided elsewhere. Unfortunately, there are still 1,600 deaths roughly each year in the United Kingdom that can be attributed either directly or indirectly to asthma. Most of these deaths occur out with hospital, and in the National Review of Asthma Deaths, there were found to be potentially preventable factors in over 60% of these deaths. Almost half of patients who died did not call for or receive any medical assistance during their final fatal attack, and 3/4 did not have a personal asthma action plan. There are still deaths occurring in the United Kingdom following the inappropriate prescription of beta blockers and non-steroidal anti-inflammatory drugs to patients with asthma. In terms of risk factors for life-threatening asthma, well, the SIGN Network, Scottish Intercollegiate Guidelines Network, in 2015 identified two main risk factors. Firstly, a background of severe asthma and adverse behavioural or psychological features. By severe asthma, they mean people with previous near-fatal asthma, those who are heavy users of beta-2 agonists, those who are repeat attenders at the emergency department, or those people who've had previous admissions for asthma, especially in the last year. In addition, patients requiring 3 or more different classes of asthma treatment. Within the SIGN guidelines, they identify multiple adverse behavioural and psychological factors. These include non-concordance with recommended therapy, monitoring and clinic appointments, fewer contacts with their general practitioner or indeed demanding frequent home visits, patients who previously self-discharged, those with a history of psychiatric illness including deliberate self-harm, and those with current or recent major tranquilizer use. In addition, patients in denial or those with a history of alcohol or drug abuse, the obese, those with learning difficulties, those with employment and income difficulties, those who are socially isolated, those under severe domestic, marital or legal stress, and finally, poor perceivers are all at risk of life-threatening asthma. By poor perceivers, these are people that don't realise just how unwell they are. People that think it is normal that they should be short of breath on minimal exertion, or think it is normal that they should be wheezing all the time, have a poor perception of what normal is. Asthma deaths can be split roughly into two groups. Type 1, or the slow onset acute asthma, represent the majority of patients who die. These people have a progressive deterioration over several days and will often arrive late in hospital. They are more commonly female, and infection is often a precipitating factor, usually a virus. They typically have high levels of eosinophils within the lungs and the blood. Mucus plugging is common. Resolution of this form of asthma tends to be quite slow, and it is possibly preventable. Type 2, or sudden onset severe asthma or sudden asphyxia, is less common. These patients are more commonly male and is typically induced by allergens or exercise or psychological stress. It's a neutrophilic inflammation rather than an eosinophilic one in this case, without mucus plugging. On the plus side, it does tend to resolve quickly. However, it is unclear if this is preventable. Near-fatal asthma, then, is a combination of two different things: dynamic hyperinflation and intrinsic PEEP. In dynamic hyperinflation, expiratory airflow limitation caused by the narrowing down of airways results in an increase in the end expiratory lung volume. Ultimately, this will interfere with respiratory muscle function, in particular the diaphragm and chest wall. The diaphragm can be flattened to such an extent that it completely reduces any efficiency of ventilation, and these patients are primarily breathing just by using their intercostal muscles and accessory muscles rather than by using the diaphragm. Intrinsic PEEP, or IPEEP, is positive alveolar pressure at end expiration, PEEP, due to the elastic recoil against airway resistance. In other words, air is trapped within the alveolus and cannot get out. The work of breathing gradually increases in the presence of intrinsic PEEP, and as a result, residual alveolar pressure has to be overcome before you get any inspiratory flow. And if you look at the flow time curve on your ventilator, you can see while the patient will have a relatively normal inspiratory phase on the ventilator, you can see they do not breathe all the way out. This leads to breath stacking. So normal is the lungs at the bottom, whereas asthmatic lungs with breath stacking at the top. You can see in normal lungs, people will inspire and expire the same volume. But in asthmatic lungs, over time, people will be expiring less than the inspire, and as a result, residual lung volume increases. Together, this hyperinflation and intrinsic PEEP will increase intrathoracic pressure and so reduce venous return to the heart and cause a reduction in cardiac output and therefore blood pressure. This also reduces CO2 elimination whilst increasing production because these patients are having to work very hard, and obviously it increases the risk of pneumothorax. So when should patients be considered for admission to intensive care? Well, the British Thoracic Society and SIGN guidelines say that obviously any patients requiring ventilatory support and those with acute, severe or life-threatening asthma failing to respond to therapy should be admitted. This includes people with a deteriorating peak expiratory flow, persisting or worsening hypoxia, hypercapnia, an arterial blood gas showing a fall in pH and acidosis, those who are exhausted or have very weak respiratory effort, anyone who is drowsy, confused or has an altered conscious state, and clearly patients who've suffered a respiratory arrest. I would also consider admitting people with a history of life-threatening asthma and previous ICU admission, and those with life-threatening asthma who will not realistically receive an appropriate level of care outside of intensive care. So what should we expect to have happened on the ward or in the emergency department before we get called from intensive care? Well, firstly, it would be good if the trigger for that asthma attack had been identified and any appropriate treatment started. Patients should have had plenty of nebulized salbutamol driven by oxygen. The common side effects of high doses of nebulized salbutamol, such as tachycardia and raised lactate, are actually quite reassuring because they do suggest patients have received adequate doses. Some centres would consider using IV salbutamol, certainly the emergency department where I work does. Ipratropium nebulizers should be given. Steroids should absolutely be given. Magnesium intravenously as well. Aminophylline is somewhat contentious. There are certainly asthmatics out there who respond to aminophylline and do benefit from it, but there is no evidence at population level for aminophylline being of any benefit to any respiratory condition. Different centres have different tolerances for aminophylline. Where I work, we do use it, but not a million miles away in a different centre, it's not used at all. I think a chest x-ray is a reasonable expectation as well, looking for any evidence of pneumothorax or infection. And I think it's reasonable to expect at least one arterial blood gas, although I can understand why frequent attenders with asthma wouldn't want to have that done. It is, after all, quite a painful test. When a patient is accepted onto intensive care with asthma, we should be continuing the treatment that started on the ward. That is, treatment of any specific trigger, lots of nebulized salbutamol and ipratropium, steroids, potentially using an intravenous beta agonist if we're unable to get adequate doses into a patient by nebulizer, potentially using intravenous aminophylline, but also we can use drugs such as adrenaline if there's cardiovascular compromise, ketamine if the patient needs sedating, it also has bronchodilatory properties. We can use inhalational volatile anesthetic agents, which are also all bronchodilators. We can, in certain circumstances, consider the use of non-invasive ventilation. Obviously, we can mechanically ventilate people invasively. We can use neuromuscular blockers. We can carry out diagnostic and therapeutic bronchoscopy. And in certain centres, we have the possibility of extracorporeal membrane oxygenation, ECMO, or extracorporeal CO2 removal, ECOR. Let's look at these treatments that we can provide in intensive care individually. Firstly, IV salbutamol. It can be considered in ventilated patients and titrated to response. Lactic acidosis, though, is very common in patients within a few hours, which will require careful monitoring or even cessation of IV salbutamol. There isn't any difference in the effectiveness between IV and nebulized salbutamol, but realistically that study didn't include people that threw their masks off. And if the patient's bronchospasm is so severe that nebulizers just certainly aren't going to get into the small airways, IV salbutamol potentially is a useful therapy. Nebulized adrenaline doesn't have any significant benefit over salbutamol. However, in cases of cardiovascular compromise, we can certainly consider IV adrenaline as a means of cardiovascular support. Not only is it a vasoconstrictor, it's also a positive inotrope and a bronchodilator. The general anesthetic and pain-killing sedative ketamine also has bronchodilatory properties. However, in awake patients, doses of ketamine that were tolerable in terms of the side effects of dysphoria didn't produce any bronchodilation. But if your patient is deeply sedated, adding in intravenous ketamine may allow you to reduce the dose of your other sedatives and may produce some benefit in terms of bronchodilation. All inhalational anesthetics will directly relax bronchial smooth muscle. This can be done in two ways. You can do it through a tight-fitting mask at a low concentration, a concentration that is insufficient to induce anesthesia, but that would be very unusual. Certainly where I work, we've never done that. More commonly, it's given via invasive ventilation in an anaesthetized patient, and the device we use is the anesthetic conserving device, or Anaconda. Essentially, this allows a syringe driver to inject the black area of the Anaconda you can see there in the picture with the volatile anesthetic agent, which then vaporizes and is blown down by the ventilator into the patient's lungs. This produces bronchodilation, but it also acts as your sedative. This is a general anesthetic after all. Non-invasive ventilation is somewhat controversial. There have been various studies done over the years, and one concluded that in spontaneously breathing patients, the application of low levels of mask CPAP may improve respiratory rate, dyspnea, and work of breathing in asthma, particularly if you're not looking at pure asthma and there's evidence of underlying smoking-related lung disease too. However, the regular use of non-invasive ventilation in asthma is controversial, and it cannot be recommended as part of routine clinical care for asthma. NIV does not allow you to measure intrinsic PEEP, and therefore the risk of applying external PEEP beyond the patient's own intrinsic PEEP as a result of their bronchospasm and causing worsening dynamic hyperinflation is very significant. That is, of course, in the context of dealing with pure asthma though, and asthma is often part of another lung disease, often smoking-related lung diseases too, in which case NIV may be of benefit to those patients. And even in pure asthma, there are patients out there who do seem to benefit from non-invasive ventilation, and I have seen it as part of some particularly brittle asthmatics' asthma management plans. The rates of intubation and mechanical ventilation in asthma vary very widely in the published literature. It can be a life-saving intervention in patients with life-threatening asthma, but it does have a high incidence of complications when compared with intubating for other causes of respiratory failure. There are some indications for mechanical ventilation though, and the absolute ones include coma, respiratory and cardiac arrest obviously, and severe refractory hypoxemia. There are also many relative indications such as adverse trajectory of response to management, fatigue or sleepiness, cardiovascular compromise, and pneumothorax. In life-threatening asthma, the induction of anaesthesia and tracheal intubation are, however, extremely hazardous. There are likely to be dramatic changes in physiology with the induction of anaesthesia, switch from high intrinsically produced negative intrathoracic pressures to high positive pressures from mechanical ventilation can cause complete cardiovascular collapse and cardiac arrest. If you are going to intubate an asthmatic, anticipate hypotension. Preload these patients with fluid. Have vasopressors available. Expect vasodilatation and a reduction in sympathetic tone on induction. Patients are often hypovolemic because they haven't been able to eat and drink normally over the days, and when they're breathing so quickly, they'll also be blowing off a lot of water vapor. There will then be a reduction in venous return as a result of high intrathoracic pressures generated by ventilating against airway resistance. Let's be honest, initial handbagging in this situation can be overenthusiastic. That can be enough to completely remove any venous return to the heart and result in a cardiac arrest. In terms of the mode of ventilation for a patient with asthma, we by and large have two choices, either constant pressure generation or constant flow generation. Constant pressure generation, certainly where I work, has the pro of being very familiar to the team. However, we would expect to see big changes in tidal volumes as bronchospasm starts to settle. Constant flow generation, on the other hand, gives us a known minute ventilation delivered and no issue when compliance changes in the lungs. However, it will often require very high inspiratory pressures to deliver that tidal volume. Extrinsic PEEP will potentially help reduce the work of breathing by up to 40% in a spontaneously breathing, invasively ventilated patient. However, as we said before, with non-invasive ventilation, it may contribute to hyperinflation and volume trauma. So what do I do then? I tend to start with a constant flow generating mode. I check the intrinsic PEEP and gas trapping using the ventilator, and I avoid any extrinsic PEEP if intrinsic PEEP is greater than approximately 10 centimeters of water. These patients typically need a very long expiratory phase. Instead of the classic 1 to 1 or 1 to 2 that you would see on most patients, it can be 1 to 5, 1 to 7, even 1 to 10 to allow them to expire and prevent breath stacking and worsening gas trapping. I will tolerate respiratory acidosis in my invasively ventilated asthmatics as long as their pH is reasonable, and I will go back and assess these patients very frequently and be prepared to change what I am doing. One of my old mentors always said to me, the right mode of ventilation for your patient is the one that works for your patient. There is no prescription for the ideal mode of ventilation in asthma. Neuromuscular blockade then may be required to facilitate mechanical ventilation. However, it is associated with an increased incidence of critical illness myopathy. This can be worsened by the fact that these patients often need steroids as well, which also increases the risk of myopathy. If you are going to use a neuromuscular blocker, atracurium, which can cause histamine release and therefore bronchospasm, should be avoided. Locally, we prefer to use rocuronium. Mucus plugging and segmental claps are common findings in patients with bad asthma, but routine bronchoscopy isn't necessary. However, if you need to clear secretions to prevent lobar claps or take deep samples for microbiology analysis, bronchoscopy can be a useful tool. Extracorporeal membrane oxygenation, ECMO, or extracorporeal carbon dioxide removal, ECOR, can also be used in asthma. It's really restricted to case reports in the adult literature at this stage rather than proper case series or ideally trials. The best indication is probably in cases where high CO2 cannot otherwise be tolerated. After the patient is discharged from intensive care, it is vital that they have a proper written management plan and additional education. They will often also need psychological support, and they should indefinitely remain under specialist respiratory physician supervision. It's worth being aware of things that look an awful lot like asthma but aren't. Significant psychological distress, vocal cord dysfunction, the cardiac wheeze of left ventricular failure, pneumonitis, perhaps as a result of chemical aspiration or aspiration of gastric contents, and chronic obstructive pulmonary disease. I once met a patient who managed to inject herself with her friend's EpiPen when she was trying to give it to her after a bee sting, and came in with difficulty in breathing, raging tachycardia, and significant problems that was initially diagnosed as asthma in the emergency department. In conclusion then, the management of asthma within critical care starts with really good management outside of critical care, and that includes in the community. Within critical care, call for help early. These patients can go off very quickly, and bear in mind that the first point of call may not be the person who can ultimately help you. There is no prescriptive best management for asthma in critical care. We're completely without an evidence base in this setting. Be aware that if you're calling for an anaesthetist to help you intubate the patient with asthma, they will, if they have any sense, probably be as scared as you are about it. These patients can become extremely unstable on induction of anaesthesia and intubation. Patients do die from asthma, but preventing these deaths is much more about community and clinic-based therapy and simple discharges than cutting-edge medicine. I hope you've enjoyed this video on the management of asthma in intensive care. If you do have any questions or comments, please leave them down below, and I hope to see you on the next one.